Now, in this section of the lecture, we will discuss some non-infectious causes of chronic meningitis. And in this, we will discuss about the malignancy associated with chronic meningitis, some chemical compounds associated with chronic meningitis, and also primary inflammation. So the malignancy associated with chronic meningitis, again, we have mononuclear cells. Other than some bacterial infections which have mononuclear or combined mononuclear polymorphonuclear cells present, mostly we see these infections can have mononuclear cells present. So in this case also mononuclear cells, elevated protein, low glucose. The diagnosis is by the repeated cytological examination of large volume of cerebrospinal fluid. So cytologic examination of cerebrospinal fluid to look for any malignant cells or look for any signs of malignancy or features which are specific, some lab findings associated with the malignancy. So we should look the cerebrospinal fluid, big volume of cerebrospinal fluid for that. Cerebrospinal fluid exam by polarizing microscopy, clonal lymphocyte markers, deposits on nerve roots or meninges seen on myelogram or contrast-enhanced MRI. Meningeal biopsy. So all these different tests are used for the diagnosis of malignancy associated with chronic meningitis. And as we know, for most of the malignancies, diagnosis biopsy is important. So in this case, meningeal biopsy, and then we should go for lymphocyte markers, and MRI exams should be done. Risk factors are associated with the malignancy associated chronic meningitis, metastatic cancer of breast, lung, stomach, or pancreas. So these are the primary sites which are mainly metastasized to the meninges, causing meningeal inflammation or infections. Melanoma is another important malignancy, lymphomas, leukemia, meningeal gliomatosis, meningeal sarcomas, cerebral dysgerminomas, meningeal melanoma, and B-cell lymphoma. So all these are different malignancies that can cause chronic meningitis. Some chemical compounds we have associated chronic meningitis associated with the chemicals. There is again mononuclear or polymorphonuclear cells, low glucose, elevated proteins present, xanthochromia weak prior to meningitis. Diagnosis is contrast-enhanced CT or MRI, cerebral angiogram to detect aneurysm present. Aneurysm is dilatation of the blood vessel. So angiogram to detect any aneurysm. Risk factors are the history of recent injection into subarachnoid space, history of sudden onset of headache, recent resection of acoustic neuroma or craniopharyngioma, epidermoid tumor of brain or spine, sometimes with dermoid sinus tract, and pituitary apoplexy. So all these are the features associated with the chemical meningitis. CNS sarcoidosis, mononuclear cells present, elevated protein, low glucose levels. And the diagnosis, you can see that's the appearance of the sarcoidosis. Diagnosis is by serum and cerebrospinal fluid, ACE level, biopsy of extraneural affected tissues, and brain lesions, meningeal biopsy. So all these are different diagnostic tests for sarcoidosis, ACE levels, which is serum and CSF. Biopsy of extraneural tissues and biopsy of the meningeal tissues. Risk factors and systemic manifestations, we have cranial nerve palsy, especially of cranial nerve 7, hypothalamic dysfunction, especially diabetes insipidus is present, abnormal chest radiograph, you can see the chest radiograph, peripheral neuropathy or myopathy. Then we have another syndrome known as Koyanagi-Harada syndrome. Koyanagi-Harada syndrome. Again, we have mononuclear cells, recurrent meningoencephalitis with uveitis, retinal detachment. So in this syndrome, we have involvement of the eyes with uveitis, retinal detachment is present, alopecia, loss of hair is also associated with lightening of eyebrows and lashes. Here you can see lightening of the eyebrows and lashes. All these are the features associated with Koyanagi-Harada syndrome. And there is dysaceusia. Dysaceusia is also present. Cataracts are associated with this syndrome. So different features, it's a syndrome, multiple conditions are present in a syndrome. It has retinal detachment, alopecia, uveitis, dysaceusia, hearing problems, difficulty in hearing, acousia is hearing, so cataracts, all these different conditions are present in this syndrome. Glaucoma is also, so mainly it's affecting the eyes, and then there is lightening of the hair, and it has some effect on the ears. Isolated granulomatous angiitis of nervous system. Mononuclear cells are present, elevated protein, angiography or meningeal biopsy should be done for the diagnosis. Risk factors and systemic manifestations are subacute dementia, memory loss, multiple cerebral infarctions, recent zoster ophthalmicus. Then we have SLE, systemic lupus erythematosus, mononuclear or polymorphonuclear anti-DNA antibody present, anti-nuclear antibody, encephalopathy, seizures, stroke, transverse myelopathy, rash, arthritis. Then we have another condition known as Bassett syndrome. Again, it's associated with mononuclear or polymorphonuclear cells, elevated protein, oral and genital aphthous ulcer. You can see these aphthous ulcer around on the lips, so it's oral and genital ulcers present in Bassett syndrome, iridocyclitis, retinal hemorrhages, pathologic lesions at the site of skin puncture, chronic benign lymphocytic meningitis, mononuclear cells again, These are the big, huge lymphocytic meningitis, lymphocytes, plasma cells. So recovery in 2 to 6 months. Diagnosis is by exclusion. Then we have Molari's meningitis. Large endothelial cells and polymorphonuclear cells in the first hour present, followed by mononuclear cells. Diagnosis is by PCR for herpes, MRI CT to rule out epidermoid tumor or dural cysts, recurrent meningitis, exclude herpes simplex virus 2, an occasional case associated with the dural cyst. Drug hypersensitivity is associated with polymorphonuclear, occasionally mononuclear cells or eosinophils. Diagnosed by complete blood count, in which we have eosinophilia present, recurrence with repeat exposure. So it's important to find out which drug the person is hypersensitive or allergic to, so they should not use that drug, but if they keep on using, the infections will be recurrent. Drugs commonly associated, we have non-steroid anti-inflammatory drugs like ibuprofen, sulfonamides, isoniazid for the tuberculosis, tolmetin, ciprofloxacin, antibiotics, penicillin. Lot of antibiotics have drug hypersensitivity, carbamazepine, lamotrigine, IV immunoglobulin, and OKT3 antibodies. Phenazopyridine. So all these are the drugs that are associated with hypersensitivity reactions. Granulomatosis with polyangiitis. Wegener's granulomatosis is the common term used. That's the X-ray picture of Wegener's granulomatosis. Then mononuclear cells associated sinus, pulmonary or renal lesions are present. Cranial nerve palsies are also present. Skin lesions, peripheral neuropathy. Diagnosis is by chest and sinus radiographs, urinalysis, and ANCA antibodies in serum. So that concludes our section 4, in which we discussed in detail different conditions, different systemic conditions also that can be associated with the chronic meningitis or meningoencephalitis. Thank you for watching sqadia.com.